Hello friends, welcome to Cortex YouTube channel. Today we are going to discuss how to interpret given LFT report. Before going to the discussion of interpretation of LFT, let's begin with the case discussion. Here is a young male complains of yellowish discoloration of eyes whenever he fasts and during stressful conditions. His LFT is given below. What is the diagnosis? In LFT, the total bilirubin is 2.72, which is elevated, and direct bilirubin looks like okay. Indirect bilirubin is elevated, and rest other parameters are within normal limits. We'll come to the diagnosis later at the end of the discussion. So we'll discuss one more case here, that is question number 2. Here is a 50-year middle-aged old diabetic hypertensive with BMI more than 35 kg per meter square with right upper quadrant discomfort. His LFT is shown. What is the diagnosis? So here the LFT is given here. Total bilirubin is elevated. Your enzymes are also elevated, where ALT is more than AST, and ALP proteins are normal. So we'll come to the diagnosis later at the end of this discussion. So let's begin with the LFT. So LFT stands for liver function test. So we should know what are the functions of liver. Liver has many roles in our body, especially metabolism. It has a metabolism. Major function is metabolism. So it has a metabolism. It has a role in metabolism of carbohydrates, proteins, and lipids, macronutrients, and micronutrients like vitamins, minerals, and hormones. So hormones I will mention separately. Hormones. And it has special metabolic function, that is bilirubin, which is measured in LFT, and it plays a very crucial role in metabolism of drugs and toxins. So these are the metabolic functions of liver, and there are few synthetic functions of liver. So it synthesizes bile acids, which are very essential in fat lipid absorption and fat soluble vitamin absorption from bile acid. Next is it produces proteins, especially albumin and clotting factors, which helps us in blood clotting. All the clotting factors are produced by the liver except factor 8, which is produced by endothelial cells of the blood vessels, and it produces TPO, thrombopoietin. So these are the few synthetic function of liver. So let's discuss one by one. So whenever you are going to interpret LFT, you should know what are the parameters that are present in the LFT. Parameters that are present in the LFT includes parameters about bilirubin, which includes total bilirubin, direct bilirubin, and total minus direct results in indirect bilirubin levels. And about enzymes. So liver enzymes present in the LFT includes your AST, ALT, ALP, GGT, and 5-alpha nucleotidase. And about proteins, we have albumin and globulin. And the synthetic function, another one is coagulation profile. In that, mainly PT, prothrombin time. So these are the parameters that are present in the LFT. Coagulation is the extra test. Okay. So let's discuss each parameters individually. So let's discuss first about bilirubin. What is exactly bilirubin? Bilirubin is nothing but, what is the source of bilirubin? Bilirubin is nothing but end product of heme metabolism. So bilirubin, so normal value when measured with DISO method like Van der Waals reaction, the normal values lies between anywhere between 1 to 1.5 milligram per deciliter. Anything more than 1.5 milligram per deciliter is your hyperbilirubinemia. So clinical icterus, if you are seeing icterus in a patient, the bilirubin level you will be at least 3 milligram per deciliter. That means to see clinically visible icterus, you need bilirubin of more than or equal to 3 milligram per deciliter. So normally, do you know how much milligram of bilirubin is produced every day? Normally, in normal individuals, 4 mg per kg, that is 4 milligram per kg of body weight is produced every day in a normal individuals. And the source of the bilirubin is 80% comes from the senescent RBC breakdown, that is hemoglobin, and rest 20% comes from hemoproteins. What are these hemoproteins? These are your myoglobin and your cytochromes, which contains heme. So major source is breakdown of senescent RBCs, that is from metabolism of heme from hemoglobin. So this is about bilirubin. And whenever you get hyperbilirubinemia, especially isolated hyperbilirubinemia, what I mean by isolated hyperbilirubinemia means isolated hyperbilirubinemia. What I mean by isolated hyperbilirubinemia means only bilirubin is elevated. Bilirubin parameters, that is TB, DB and IVs are elevated. Rest of the LFT is normal, within normal limits. So your enzymes and proteins are normal. Only total bilirubin, direct bilirubin and indirect bilirubins are elevated. So in that condition, it is called as isolated hyperbilirubinemia. In that condition, what should be your approach? So whenever you get isolated elevated bilirubin, so you have to fractionate whether direct bilirubin is more or indirect bilirubin is more. So if the direct, you have to see the direct bilirubin, if it is more than 15% of total bilirubin, you can consider direct hyperbilirubinemia. That means conjugated hyperbilirubinemia. So here you have to think in terms of two conditions, that is your Dubin-Johnson syndrome and Rotor syndrome, where your excretion of conjugated bilirubin mechanism is defective. And whenever you get direct bilirubin less than 15% of total bilirubin, so this suggests, see, that means less direct bilirubin means more indirect hyperbilirubinemia. So it is indirect hyperbilirubinemia. So whenever you get in this pattern, whenever you get indirect hyperbilirubinemia, first thing that you have to rule out is hemolysis. How to know that there is hemolysis? So you have to check for haptoglobin and LDH, and peripheral smear showing hemolysis. So haptoglobin, LDH, when this is present, when hemolysis is present, so you have to work up for hemolytic anemia. That indirect hyperbilirubinemia is because of hemolytic anemia, and work up for hemolytic anemia. Hemolytic anemia has many causes. So many causes are there. It could be because of enzyme deficiency like GCCVD deficiency, PK deficiency, or it could be because of membrane defects, spherocytosis, ellipticocytosis, or sickle cell disease. So many things, drugs. Okay, hemolytic anemia, autoimmune mechanism. So many conditions are there. So you have to work up for hemolytic anemia. Next is when this signs of hemolysis is absent. Next thing that you have to consider is drugs. History of drugs you have to rule out. What are the drugs which known to cause indirect hyperbilirubinemia? Here the mechanism of drug induced indirect hyperbilirubinemia is because of drugs which interferes in uptake of unconjugated bilirubin by the liver cells, that causes indirect hyperbilirubinemia. So what are those drugs? Rifampicin and probenecid. So these are the known drugs which causes impaired uptake and causing indirect hyperlipidemia. So when drugs are not there, no drug history. So after ruling out drugs, no drugs. So that time you have to think in terms of two genetic conditions that are your Gilbert syndrome and Crigler-Najjar syndrome. Okay, Crigler-Najjar and Gilbert syndrome. Crigler-Najjar again type 1, type 2. Type 1 has absent enzyme UDP enzyme activity. Type 2 has less 10% of enzyme activity, and Crigler-Najjar is more severe compared to Gilbert syndrome. Gilbert syndrome, only 30% of the enzyme activity is reduced because of mutations in the UDP gene. So this is the workup for patients having isolated hyperbilirubinemia. Okay, I hope you understood this. So let's now go over. This is the discussion related to bilirubin. So one more thing that I want to discuss here is, whenever bilirubin, see, normally bilirubin is not found in urine. So if you get bilirubin in urine, that means dark colored urine. Okay, that means you are dealing with conjugated, that is direct hyperbilirubinemia. Okay, that is one clinical point that I want you to know. So just by, see, your clinical icterus is not, it will tell hyperbilirubinemia, but it doesn't tell whether it is direct or indirect or conjugated or unconjugated. So you are looking at the urine, you can tell whether it is direct or indirect. So if urine is dark colored, yellow colored, it is suggestive of conjugated hyperbilirubinemia, that is direct hyperbilirubinemia. So one thing that you have to look clinical sign to differentiate whether direct or indirect, you look for urine color. Next we will discuss about enzymes. So enzymes, here we are going to discuss mainly about aminotransferases. Transferases, the name only tells it transfers amino acids from alanine and aspartate to alpha ketogluteric acid. So the enzymes are AST and ALT. AST was formerly called as SGOT, remember, son of SO, and ALT formerly was known as SGPT. So they can usually called in practice OTPT, STLT. Okay, OTPT is the commonly used abbreviations for AST and ALT. Okay, so other enzymes includes your ALP, GGT, and 5-alpha nucleotidase. And we don't discuss much about GGT and alpha nucleotidase because of less clinical significance, but their only significance in clinical practice while interpreting LFT is whether to differentiate, whether to know the elevated ALP is because of hepatocellular or non-hepatocellular causes. So let's discuss about AST. AST is nothing but aspartate aminotransferase, or SGOT. So AST is, it is I would say, whenever they are raised AST and ALT are there, that will suggest more sensitive markers for hepatocellular injury. So AST, if you want to discuss about AST is present abundant in more in if you take decreasing order, it is more in liver, cardiac muscle, skeletal muscle, kidney and brain, pancreas and lungs, WBCs and RBCs. So if you see the number of tissues, it is more in many other tissues also in decreasing. This is in decreasing order, more in liver, obviously more in liver, but it can be seen in cardiac, skeletal. So whenever there is MI, severe extensive MI, you will get raised AST. And even in skeletal muscle injuries like in rhabdomyolysis, acute rhabdomyolysis, myopathies, you will get raised AST. And obviously in lung and WBC, sometimes you will get raised AST. So this, though it is present in a wide variety of tissues, this very fact that it's present in many other conditions and it is elevated in the diseases of many other conditions, well, makes it more unreliable, that is less specific. It is less specific and sensitive for liver injury. In contrast to this, ALT has L, so liver, so it is a more sensitive marker for liver injury. So one more point I want to tell about AST is it is both cytosolic, it is present in cytosol and mitochondria. Okay, and one more thing that I want to discuss here, I would like to discuss about AST is AST has less half-life T half than ALT. That means ALT is cleared faster than the AST is cleared faster than the ALT. So this is about AST. Let's now discuss about ALT. ALT is more sensitive marker, more sensitive compared to AST. Sensitive marker for liver hepatocellular injury. HC means hepatocellular. Okay, and it's also it's more abundantly found in liver, and its cofactor it's a cofactor is pyridoxal pyrophosphate, that is where vitamin B6. So whenever there is a reduced B6, you won't have much of ALT. So especially in alcoholic liver disease patients, why there is typical AST ALT ratio more than 2 is because of deficiency of B6, which will reduce the synthesis of ALT. And obviously ALT has more half-life compared to AST, so ALT takes more, it will stay more longer time in plasma compared to AST. So this will help one in a very important clinical point, that is star mark you can note here. So reversal of this ratio, AST ALT ratio, in a known patient, reversal of AST ALT ratio tells about recovery, clinical recovery. So let's suppose one example, alcoholic patient or some liver injury patient, when initial AST ALT ratio is more, and during the course of treatment, course of hospitalization, this ratio reverses. That means he is going for recovery. So this is the clinical importance. And to be more specific, T half of ALT is nearly 3 times that of AST. Okay, so that's why AST is cleared more rapidly than ALT. So ALT is only cytosolic. It's present in only cytosol of the cells, not in mitochondria. Okay, so this is about ALT and AST. We will look at the approach to raise these enzymes. So whenever you get transaminitis, whenever the levels of AST and ALT are raised, we call it as transaminitis. So whenever you have raised elevated AST or ALT, so what should be your approach? So first thing that you have to know is whether AST is more than ALT or ALT is more than AST. So let's look at the situation where your ALT is more than AST. Okay, ALT is more than AST. So what should be your approach? Whenever you get such a situation where ALT is more than AST, you have to look for the values, whether absolute values are more than 1000 or mildly increased or less than 150. So when the levels are more than 1000 or more than 20 to 25 times the normal, so you have to consider few differential diagnoses. What are those? Those includes your acute bile obstruction, acute Budd-Chiari syndrome, and acute viral hepatitis. Remember, it is acute viral hepatitis. And your ischemic hepatitis. Ischemic hepatitis and your drugs and toxins and Wilson's disease. Wilson's disease, especially when it presents as fulminant hepatitis, not chronic form, fulminant hepatitis. And some autoimmune conditions. Autoimmune hepatitis. So these, and one more condition that I want to mention here is hepatic artery ligation. So these are the few conditions where you get raised ALT which is more than AST, and there is acute severe rise in the levels. It's more than 1000, values will be more than 1000 or 20 to 25 times of normal. So one condition is acute bile obstruction, acute buddleia, acute viral hepatitis, ischemic hepatitis, drugs, toxins, Wilson's disease, and autoimmune hepatitis. So these are the conditions when there is ALT more than AST and values are more than 1000, severe acute rise. So what if the values are mildly increased or less than 150 or 5 times the normal limit? So when this is the situation, you have to have few differential diagnoses which I am going to mention now. One is, so first you have to divide whether it is hepatic or hepatic causes includes NAFLD, non-alcoholic fatty liver disease. Here clinical clues will be patient will be obese, diabetic and hypertensive, okay, and family history will be there. And chronic viral hepatitis, and autoimmune hepatitis, chronic form hepatitis, your hemochromatosis, and your Wilson's disease, chronic form, not the fulminant one, and your alpha 1 antitrypsin deficiency syndrome, and simple steatohepatitis will have the pattern of raised enzymes like this. So whenever you get raised AST, ALT, that is transaminitis, you have to look for the values whether ALT is more than AST. When ALT is more than AST, look for the value, absolute values, whether it is more than 1000 or less than 150. When these are the situation, so these are the differential diagnosis. So I forgot to mention here non-hepatic causes of mild reduced. So here non-hepatic causes includes celiac disease, and hyperthyroidism. These are the diseases which presents like ALT more than AST with values less than 150 or 5 times the normal. So this is the differential diagnosis when you get this pattern of raised enzymes. Now let's look at the pattern when it is AST which is more than ALT. So here next page I am going to mention here. So there is raised ALT and AST. The pattern is here AST more than ALT. Again you have to divide whether the values are more than 1000 or less than 150. So what if the severe acute severe rise, severe and acute, that means more than 1000. So here you have to suspect drugs and medications, drugs and toxins in underlying alcoholic liver disease, okay, and rhabdomyolysis, that is acute skeletal muscular injury, rhabdomyolysis. So these are the two conditions in this pattern. And what if the values are less than 150 or 5 times the normal limit? So here you have to consider a ratio. What is the ratio? AST ALT ratio. You have to see whether it is more than 1 means it's suggestive of more cirrhosis in underlying chronic liver disease, and more than 2 it is suggestive of alcoholic related liver injury. If it is more than 3, it is highly suggestive of alcohol liver disease. And other things that suggest ALDs, and your AST will never be more than 300 milligram per international units per liter. Okay, so this is the approach when you get raised AST and ALT. Hope you understood this. So next enzyme that we are going to talk about is ALP. So what is about ALP? ALP is an again very important enzyme. Okay, ALP means alkaline phosphatase. Alkaline phosphatase is present across the body. Many different tissues will have ALP. Okay, it is present in your liver, bone, intestine, and proximal convoluted tubule of kidney, PCT of kidney, placenta. Okay, and ALP varies according to age, gender. Okay, then its normal values are very controversial. Some mentions 82, 240, some mentions 115, some mentions up to 150. So you go with the lab that will provide the normal range along with the test results. So one interesting fact about ALP is patients with blood group O and A have raised ALP of intestinal origin, intestinal ALP, whenever they consume fatty meal. So this is, I thought it is interesting fact, so I mentioned here fatty meal. Okay, so whenever you get raised ALP, you should know whether it is a hepatocellular injury or because of other causes like bone causes. Which are the bone causes that results in raised ALP? They are like Peyer's disease, osteomalacia, rickets, osteoporosis, so many conditions. And intestinal and placenta in pregnancy, adolescence, all these conditions will cause raised ALP. In case of hepatocellular injury, raised ALP means cholestatic liver injury. So there are other conditions where you get low levels of ALP. Those includes your fulminant Wilson's disease, hypophosphatemia, hemolytic anemia, malnutrition, hypothyroidism, alcoholism. All these conditions may have low levels of ALP. So what is your approach whenever you have increased ALP? So let's discuss that. So you got raised ALP. So ideally you have to do plasma electrophoresis to differentiate whether it is intestinal, placental, bone or liver ALP, because they are isoenzymes and they have typical electrophoretic pattern. That is not possible clinical practice in routine clinical practice. So one more accepted alternative method is your GGT. Look at the GGT and 5-alpha nucleotidase. If they are normal, so you have to consider other causes of elevated ALP like your bone pregnancy. So if they are also elevated, so here they suggest cholestatic pattern, that is obstructive pattern. So whenever you get such pattern, initial first thing that you have to do is ruling of the drugs causing cholestatic pattern. Okay, drugs causing cholestatic pattern. So I will mention them in the end, at the end. So cholestatic, so rule out of drugs first. If history of drug intake is not there, USG, you have to do USG. That to CBD, you have to mainly look for CBD, whether it is dilated or non-dilated. If it is dilated, it suggests extrahepatic cholestasis. So extrahepatic cholestasis, so here you have to do CT, abdomen and MRCP. So if it is non-dilated, then what to do? It may be intrahepatic. So intrahepatic cholestasis, okay, here you have to do AMA, anti-mitochondrial antibodies. If it is positive, you have to make the diagnosis of PBC. In PBC there is also raised IgM, and you have to confirm the diagnosis by liver biopsy. So if AMA is negative, so you have to think other diagnosis like primary sclerosing cholangitis and granulomatous diseases like sarcoidosis and chronic viral hepatitis. Okay, sarcoidosis, here ACE levels, angiotensin converting enzymes levels will be raised, and again biopsy is the confirmatory, and it is also characterized by extrahepatic manifestations. Okay, viral hepatitis. Sometimes viral hepatitis also presents with cholestatic pattern of enzyme elevation. So this is the approach when you have raised ALP. One more thing I would like to discuss here is R factor. R factor helps to differentiate whether it is mixed pattern, hepatocellular pattern or cholestatic pattern. I have discussed in detail about R factor in a video which is present, which I am the link of which is will be available in description or in I button. You can click that and you can watch. And regarding this drugs causing cholestatic, I have discussed in one more video, that the link will be present in the description. You can go through that. So this is the approach whenever we get raised ALP. Okay, next thing that is present in the LFT is your proteins. So proteins majority is albumin. So albumin is exclusively produced by liver. The half-life of albumin is 14 to 21 days. So, and one important point when you can note here, one important point about albumin is whenever there is when liver is normal, whenever there is liver normal, and the other causes of hypoalbumin like nephrotic syndrome or protein losing enteropathy, liver can significantly increase. Liver can double the production of albumin. In other causes of hypoalbuminemia, right, decrease albumin. Let's suppose in nephrotic syndrome, protein losing enteropathy, liver can increase the production, but it can double the production of albumin. Okay, this is one clinical important. And one more clinical important, whenever there is hypoalbuminemia, it suggests chronicity. So in acute liver injury, albumin is not a marker for acute liver injury, it is a marker for chronic liver injury. So hypoalbuminemia means chronic liver disease. Next thing about albumin is, interesting facts about albumin is how much albumin is produced every day. That is interesting. So around I think 14 grams. 15 grams per day. Albumin is produced around 15 grams per day, and total of around 300 to 500 grams is present and distributed in across the body fluids. So this is about albumin. And other proteins includes your globulins. Globulins are not produced by the liver, but their half-life depends upon liver functionality. Globulins are produced by obvious liver plasma cells, and relevance of globulins in LFT is when you get a raised IgG in chronic liver disease, and raised IgA, A for alcoholic liver disease, and IgM, I already told, it is seen in primary biliary cholangitis, PBC. And whenever there is a reversal of AG ratio is reversed in chronic liver disease. Normally bilirubin albumin will be around 2 and globulin around 2, so it will be more than 1. So a ratio will be more than 1 in normal, but this reversal of ratio, that is less than 1, happens in chronic liver disease. So this is about relevance of proteins in case of interpreting LFT. And one more thing, parameter that helps is clotting factors. So all the clotting factors, all CF clotting factors produced in the liver, except it can come as MCQ, except factor 8, which is produced by endothelial cells of the blood vessels. Now what are the so here prothrombin time is a sensitive marker. PT is a sensitive marker for liver injury because PT obviously prothrombin time depends on factors 10729. There is one mnemonic you can remember, like it is 1729. 1729 is a Ramanujan's number, which is smallest possible number, which can be expressed as sums of cubes of two different number in two different way. So you just have to make 1 as 10. So 10729 are your vitamin K dependent clotting factors, and okay, vitamin K dependent clotting factors, they help in prothrombin time. So in that sensitive marker is clotting factor F, clotting factor 7, because it has a short half-life, shortest T half, that is around 6 hours. So even in case of acute liver injury, acute liver failure, prothrombin time can be a prognostic marker because of the shortest half-life of factor 7. Okay. How much is the reduction of these factors will cause prolongation of PT? So around 30%, of the activity has to be reduced, or levels, 30% of the levels, 30% of a normal level has to be reduced to cause prolongation of PT. So this is about LFT, okay, liver function test. So I hope you understood this, whatever I told, and let's go back to those questions and try to interpret the LFT reports. So yeah, the first question. So young male complains of yellowish discoloration of eyes whenever he fasts and during stressful conditions. His LFT is given. So TB. So total bilirubin is 2.72 and indirect bilirubin is 2.73. So whenever you get, so here rest of the parameters are normal. That means we are dealing with isolated hyperbilirubinemia. So you have total bilirubin is elevated. So in that condition you have to look for direct bilirubin, whether it is less than 15% or more than 15%. So if you look at the direct bilirubin, it will be less than 15%, 15% of total bilirubin. 2.72 into 15% means it comes around 0.4. So direct bilirubin is less than 0.4. So we are dealing with, it is less than 15%. In this case we are dealing with indirect hyperbilirubinemia. So whenever you get such things, we have to rule out hemolysis. So the very fact that they have not given anything about CBC or hemolytic, so here hemolysis is unlikely, and drugs also they have not mentioned anything about the drugs. So we are dealing with non-hemolytic, non-drug induced indirect hyperbilirubinemia. So we can think in terms of genetic conditions like Gilbert and Klickler-Nager. So this case is Gilbert syndrome because there is a clue here that yellowish discoloration happens when he is fast and during stressful conditions. So during stressful conditions, the enzyme activity that is present, that will also decrease, so you get more jaundice. So here this is the case of Gilbert syndrome. Hope you understood. Next we'll go to another clinical scenario here. A 50-year-old diabetic, okay, there is a diabetic, hypertensive and BMI is more obese patients. So obese and diabetic patients and liver condition means we have to think in terms of NAFLD, or now it's called as metabolic associated liver disease. Okay. With right upper quadrant discomfort. So LFT is shown. What is your diagnosis? So here total bilirubin is elevated, direct bilirubin is elevated, indirect is also elevated, and look at the enzymes, they are elevated. ALP is normal, proteins are normal. So we are dealing with transaminities. So whenever we are dealing with raised AST and ALT. One thing I told is, first thing that you have to look for is whether engine pattern, whether AST ALT ratio, whether ALT is more than AST or AST more than ALT. In this condition, ALT is more than AST, so 134 is more than 198. So, and ABS values are less than 150 or 5%, 5 times the normal limits. So here you have to think in terms of NAFLD, non-alcoholic fatty liver disease, chronic viral hepatitis, Wilson's, hemochromatosis, autoimmune hepatitis. Okay, so these are the conditions. But in this case, it is a 50-year-old. So Wilson's disease and hemochromatosis are unlikely. Autoimmune hepatitis are unlikely. They present with younger age group, and then there is significant history that is given here, that is diabetes and obesity. So they are more favoring the diagnosis of NAFLD. So here I will go with diagnosis of NAFLD, NASH, or NAFLD, non-alcoholic fatty liver disease, which is now called as metabolic associated fatty liver disease. Okay, hope you understood this. And if you like this video, please share and like, and subscribe to the Cortex YouTube channel. Thank you. Okay, in coming videos I'll be interpreting more different types of electives. Please follow. Thank you.